Hello, welcome to the San Antonio Breast Cancer Symposium. I'm Richard Sainsbury, I'm a breast surgeon, and I've chosen to talk today about 3 papers looking at contralateral prophylactic mastectomy. This is certainly something that's exercising me in my clinics, and I thought these were interesting presentations. Although Angelina didn't feature in any of the 3 presentations on the oral platform, there were certainly a couple of posters showing her, and one quite intelligent poster that looked at the effect on genetic clinics in America of the Angelina effect, and showing that initially in the first 6 to 9 months, a lot of women who were actually gene carriers, even though they didn't know they were gene carriers at the time, came out of the woodwork for genetic testing and went forward for contralateral prophylactic mastectomy. But that was then followed by a tail over the next 18 months of non-gene carriers, but they estimate that they had to triple the amount of genetic provision just based on the effect of Angelina Jolie publicizing her bilateral mastectomy. And certainly I think many of us in the UK are finding that our clinics are getting fuller of women asking or inquiring about whether this is relevant for them. And they're not simple and easy cases to discuss. It's quite clear that there is an increasing trend in contralateral prophylactic mastectomy. These 4 graphs show the different age groups. Top left panel is those under 40, and it's the lower graph in blue with the rapid increase over the last few years, showing the rising increase in contralateral mastectomy. The top right panel is those between 40 and 50. Bottom left panel 50 to 65, and even in the over 65s there is an increase in the take-up of contralateral mastectomy, but it's obviously small. And when we look specifically at the younger women, here's a young women's breast cancer study, so these are the under 35s, showing that whilst breast conserving surgery has increased as unilateral mastectomies dropped away, contralateral mastectomy is becoming quite a common operation. So how does the decision making go? And obviously the risk-benefit ratio has to be explained, and you might think some of the benefits would be obviously decreased risk of contralateral breast cancer, although it's interesting that this has reduced over the last decade and is now running at a much lower figure with modern treatments, adjuvant treatments for the unilateral breast cancer. So reduction in risk of breast cancer is often quoted, but is in fact overestimated. There's obviously a diminished need for surveillance, although depending how the contralateral mastectomy has been done, there will still be some need for surveillance if thick flaps have been used or breast tissue has been left. One additional benefit that comes over in some of the studies is cosmetic symmetry. If someone's had a unilateral mastectomy and a reconstruction, they never get a breast that's as good as their contralateral breast. And some women are saying, well, I'd rather reduce the risk but have symmetry, even though it may not be as attractive as it was before. The risks obviously are of the risks of any surgery and operative complications. Breast reconstruction is not a simple procedure, and the median number of operations is 4 for a patient. So that needs to be taken into consideration, along with the need for follow-up procedures. If you're going to use implants, and although we think they last 15 years, they're still going to need changing once or twice during a patient's lifetime. Also out there are these figures from the SEER dataset. So this is a subset of 25, nearly 26,000 patients who had a contralateral prophylactic mastectomy out of 400,000 patients in the 2 years of this study. And it became clear from the publications that contralateral mastectomy reduced the risk of breast cancer-specific mortality by 16%, which is a significant figure. There was lower all-cause mortality, 17%. But what's interesting is there was a lower non-cancer mortality with a 29% reduction. So what this shows is that this is a highly selected population. This is a population that have made these choices, that are probably better educated, that are probably a higher social economic status, who are always going to do better anyway. And so this statistic needs to be interpreted with caution. When people were asked why they chose a contralateral prophylactic mastectomy, this is a study of Rosenberg that was reported in the Annals of Internal Medicine a couple of years ago. And there's only 89 patients who were proven to be non-carriers, but they had been tested, so that was important. And the figures that would split into extremely important, important, somewhat important, not at all important, and not sure. But the desire to lower the chance of getting cancer in the other breast was extremely important in 80% of patients, as was the desire for peace of mind. And this is something that really hadn't been investigated before this questionnaire went out, about this concept of peace of mind. And it's something that I think drives a lot of women to make this choice. Desire to improve survival or extend life, 74% felt it was extremely important, even though they knew that it didn't, the figures showed that it doesn't actually impact on survival. Desire to prevent breast cancer from spreading, though again, the index cancer is more likely to be the one that causes any metastasis, and therefore, the risk of that's already been determined, and contralateral mastectomy won't affect that. So, and then there were other studies in strong family history of breast cancer and desire to make the breast look better. So, what's going on? This is basically an American set of data, and I think information or lack of information is not one of the big problems. I'm sure there may be women out there who don't have a complete set of information, but given that this is an educated population, most have been on the web, most have been on support groups, and they come very well informed. So what else is going on? They may be told, but they may not remember it accurately. And this is something that has been shown in some of these studies, is that the recall of the information is poor. Some believe that any risk is too much risk, even though they probably had their risks already by developing the first breast cancer. And many of them are unable to comprehend their risk. If they look at risk perceptions and knowledge about contralateral mastectomy, those who don't carry the BRCA1 and 2 gene overestimate their risk by 20 to 30-fold. So they feel that they've got a 10% chance of developing contralateral breast cancer within 10 years if they don't have a mastectomy, and that figure is much higher than there. Interestingly, those who are gene carriers have a much better comprehension of their risk, probably because they've been through the genetic service. Some of them are unable to actually work out how that risk is relevant to them, and they may feel that a 2% risk is too high, and if that could be reduced by surgery, they'll do anything for it. And others are worried about the risk. They say, you've already told me my risk of getting breast cancer at my age was low. I'm obviously marked out. Why am I not going to be the one that gets it again? And that's a very difficult argument to counter. There was a subset study looking in, again, the SEER dataset of 1,500 women who were strongly considering contralateral prophylactic mastectomy. So they came forward to inquire about it. Only 7.6% actually went through with it. So of those considering it, of those 18.9%, that 7.6 represents the 32.2% who received the contralateral mastectomy. 45% went forward and had a unilateral mastectomy, and just under a third had breast conservation surgery. So these are de novo cancers. This is not delayed contralateral mastectomy. This is upfront contralateral mastectomy. And the majority of the patients who received the contralateral mastectomy had no genetic or familial risk factors for contralateral disease, but they just felt it was the right decision for them. And when the study was analysed, a multivariate regression analysis for contralateral prophylactic mastectomy, or risk of getting contralateral mastectomy, it was associated with anyone who has a genetic test. So whether that test was positive or negative, interestingly, even if you were reassured that you weren't a gene carrier, that's still predicted for going ahead with contralateral mastectomy. Strong family history of breast and ovarian cancer, which one might understand. Having an MRI, that dreaded MRI, which is often thrown in for reassurance rather than because that will show up something where there is uncertainty about what's going on in the breast, and that will often drive a woman to say, look, doc, if you don't know, How can I be sure that I'm making the right decision? Let's remove it. Higher education, because they're more likely to access the web and support groups. And worry about recurrence. And it's interesting that those who begin to worry about getting a recurrence leads to an inaccurate risk perception. And so those that can be reassured and understand that their recurrence risk is low actually regain a better perspective on their risk. And then the other thing that wasn't studied in this study but does come out from other studies is that better symmetry over a unilateral mastectomy, as we discussed earlier. In the very young women, so this is looking at those under 35s, having a child against being nulliparous was an important risk factor, a larger tumour, being tested, having an MRI or higher anxiety scores, fear of recurrence, and who made the decision, whether it was their decision or it was made in conjunction with their doctor, were all predictors of contralateral mastectomy. So who did make the decision? And it's interesting that if we look at the percentage of women having breast-conserving surgery, unilateral mastectomy, bilateral mastectomy, those who ended up with the bilateral mastectomy, it was mainly their decision. This was not something the docs were pushing. And so the right-hand panel shows that very few doctors actually led off or pushed for or suggested that a bilateral mastectomy was the appropriate thing. Some of them in the group in the middle, they achieved a symmetry of response, but many women felt they had to push for this operation and that they had to push hard to persuade the doctors that they wanted this operation. So the concept of patient-centered care, where you put the patient at the front, you provide care that's respectful, responsible for their preferences, needs, values, and that they get the right information. But it's actually a difficult concept to take into the clinic and to make sure that every patient gets this. And what it doesn't mean is that you give patients what they want. And I sometimes feel, having spent an hour or an hour and a half with a patient who's coming to inquire about contralateral mastectomy, either as a delayed procedure or as an immediate procedure, that at the end of it, I rather feel like the GP who's been asked to give antibiotics for someone with a cold and has spent 10 minutes giving all the evidence that antibiotics don't shorten a cold, but at the end, just sign the script and get on with it. And I've certainly, I have to admit, had times when one's felt that however much information you give the patient, they've come with this determination that it's their right to have a bilateral mastectomy, and whatever you say, even though you're going to be the one doing the operation and they have faith in you as the surgeon, but almost they feel that you're trying to block them from having this operation. And it's a very difficult group sometimes to get through. That's why I think good support from breast nurses, psychologists maybe, certainly some counsellors, with the appropriate information is vital if you're going to undertake this sort of work. So in addition to this contralateral mastectomy decision-making that we looked at earlier, I think peace of mind comes out as one of the major determinants for these women, and it's something that we must bear in mind, and that many of them will sleep better and be happier people if they have this operation. So to conclude, women out there are making decisions based on inaccurate risk perceptions and understanding, and even with adequate information and psychological support, the decision-making process is not clear and may not be one that we feel is justifiable. So these areas potentially are modifiable, and I think that we're going to need to invest more time because this is an operation that's not going away in the short term.